Good afternoon, everyone. It's 4 o'clock. Welcome everybody to another edition of our Nigerian Orthopaedic Association series of lectures. Today, we're going to have a very interesting topic from one of our chiefs, Dr. Mustafa Alimi, the medical director of Nigerian National Orthopedic Hospital, Igbobi, Lagos. He's going to be talking to us today about acute back pain. As usual, I just want to remind us about our rules. Please mute your microphones once while the lecture is going on. At the end of the lecture, we'll have the opportunity to ask questions. You can put up some questions in the chat box as we go along, or you can wait till the end of the lecture and you'll be given the opportunity to ask the questions directly. So without much ado, I'll call on Dr. Alimi to please start with the presentation today. Dr. Alimi, sir.
Good afternoon, sir.
You're welcome, sir.
Thank you very much. I'll share my screen now. Good afternoon, everybody. This topic, the acute painful back. Now, by definition, the back is that back of is the posterior part of your body that is caudally stops at the buttocks and the cephalad at the neck. So between your neck, or between my neck and the buttock, lies the back. The back can be divided into upper, middle, or lower back. Now, the upper back is actually often described as the area that is covered from the first thoracic till like the 9th thoracic. The 10th, 11th, 12th thoracic vertebra and the first and second lumbar are often described as the middle back. And below the second lumbar vertebra is described as the low back. That also covers the sacrum as well. But there are those who have divided the back into just upper and lower, that is thoracic and lumbar. Now, since we're saying the topic is acute painful back, so let's define what pain is. For ease, you can say pain is just that uncomfortable sensation that you have in your body. But WHO has defined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So the presence of pain does not necessarily have to have tissue damage, and it's an emotion, it's an experience that is personal. So if a patient says he has pain, you don't have the right to say he doesn't have pain. Now, back pain, you must understand, is not a disease. It's just a symptom of a disease. And back pain can be caused by pathologies within and around lesions that are located around the spine. Now, since we said acute, what do we mean by acute back pain now? We're not talking about back pain that lasts less than 6 weeks. The subacute type lasts between 6 weeks to 12 weeks, and the chronic back pain is described as the one that exceeds 12 weeks. Also, in defining back pain, we can also define back pain based on specificity and non-specificity. Now, non-specific back pain has been described as that pain that you cannot relate to an organic condition, and it's thought to just stay for a short while, maybe 3-4 weeks, and usually does not require any specific therapy. Analgesia alone is enough to treat it. But specific back pain is pain that you can relate to a particular cause and organic condition. Now, when we talk about pain, we must understand that pain must be generated and it must be conducted. Now, without doubt, nerve and pain conduction is by nerves. But pain generation now, there are quite a number of receptors that are responsible in terms of pain generation. We'll get there. But oftentimes we try to relate pain to a pathology and an anatomic area, which we think primarily caused that back pain. Now, as a clinician, it's your responsibility to try and relate pain to a pathology and such that it makes clinical sense. But as we go along, we'll see that this is not always the situation. Now, there are two schools of thoughts regarding pain generation. The first school of thought says that it is multifactorial, that pain generation is a combination of mechanical, psychological, and neurophysiologic contribution. Not necessarily not necessarily one pathology by in or by itself being the pain generator. Now, you and I can relate to this, that because it's not every patient that presents to you that you can actually put in a pattern. Of course, many of your patients, you can pattern, the history of physical examination can fall into a pattern of a particular disease. But there are patients who present to you that you will just find difficult to put in any particular pattern. And that is what this school of thought is trying to relate. And it's also trying to say that, look, pain in itself is not absolutely biomedical. Then the second school of thought, that is the single disabling pathology school, that describes a pain generator as the key to spine evaluation. It says that, look, you have to be able to relate a particular pathology or pathoanatomy to pain. Now, this is what most of us tend to subscribe to. As doctors, we were trained to be biomedical. You must be able to relate the biology of a disease directly to the disease that is causing pain. And it makes more sense to the physician, and it helps him in managing the patient. But it does not explain psychological issues and secondary causes of pain. So both schools of thought, there's a third group of scientists who don't accept both schools of thought, and they feel that both schools of thought should be applied as it fits particular patients. Therefore, you can understand that pain is not biology related to disease. Pain has been described now as being is a biological part, there's a psychological part to pain, and there's a social part to pain. And that is why two different people present to you with the same disease condition, but different expressions of pain. Now, where are the pain generators? If you look at the spine, within the spine, the disc is a pain generator. The annulus of the disc is well innervated by afferent nerve fibers. And then the disc itself, the nucleus pulposus, produces phospholipase, which regulates the arachidonic acid pathway. The bones themselves, the vertebral bodies, and their periosteum are well innervated with pain fibers. Nerve roots, we're talking about pain. Nerve roots will help or will generate neuropathic pain. The disc can generate a neuropathic pain as well as a nociceptive pain. But bones often generate nociceptive pain. Facet joints, they have mechanosensitive afferent fibers, and they generate their own pain through their anatomy. Don't forget that the facet joint is like a small knee joint. So it goes through the normal stages of osteoarthritis that the knee joint goes through. Therefore, once the cartilage is either cleaved or eroded and you have exposure of bone, it can present as pain. The capsule itself, the thickness of the capsule, once the capsule becomes thick and it becomes less resilient to flexion and extension movement, it can also be a pain generator. The facet joints are innervated by the medial branch of dorsal rami of the vertebra from above and below, which makes sense because the facet joint is contributed to by structures from the above and the below vertebra. Spinal muscles usually have mainly mechanoreceptors and they generate pain from stretch and pressure and from the accumulation of toxic metabolites in lactic, such as lactic acids. No. Spinal ligaments, the ligamentum flavum, the posterior longitudinal ligaments, the anterior longitudinal ligaments, all are pain. They are pain generators. They have stretch receptors, and they are well innervated by pain fibers, as well as the sacroiliac joint. Now, what is the message here? The message here is that you can have a pathology emanating from any of those structures, and the pain will be generated through more than one means. It can be from mechanical means, it can be from toxic metabolites, it can also be neuropathic. Now, visceral non-spinal sources of pain include, ignore the low there, include thoracic structures such as the pleura, the lungs, the ribs, peritoneal inflammation, and structures, gallbladder, pancreas, kidney, and stomach as discomfort, they are dysfunctions. Now, talking about pain, now let's try and discuss about the causes of pain. Now, since we're talking about causes of back pain, we can classify it into spondylogenic. Spondylogenic back pain means that pain that is generated primarily from the structures that are mainly of the spine. We're talking about the vertebral bodies, disc, the facet joints. Now, neurogenic etiological cause of back pain will be from nerve irritation. These are mainly nociceptive and neuropathic kinds of pain. Now, viscerogenic pain will be pain that is emanating from organs around the area where pain is being generated. For example, it can be the pleura, it can be from the lungs, it can be from the colons, it can be from the prostate, it can be from the pelvis. These are the viscera around the spine in those areas. Vascular pains from vascular disorders, as well as psychogenic pains, can also be types of classification. Let's now go into details. Now, just like I said earlier on, spondylogenic pains are defined as pain derived from the spinal column and its associated structures. Bony components, facet joints, sacroiliac joints, soft tissues including discs, ligaments, as well as muscles. Now, these particular sets of pain have a peculiarity. They are generally aggravated by movement and relieved by rest. But this description is not sacrosanct. It's just a general description of their pain pattern. Now, the common pain patterns that you have in spondylogenic back pain, can be further broken down into like 5. The structural spinal disorders, the inflammatory spinal pain, tumors, infections, and traumas. And so we take them one by one. Now, structural spinal disorders is just another word for degenerative spine. Now, you and I know that degenerative spine can either be degenerative disc or degenerative disc disease. But whichever one you want to talk about, you're going to start with the discs. So any disorder in any of these structures will generate back pain. If it's in thoracic spine, it can generate thoracic back pain. If it's lumbar spine, it can generate lumbar back pain. Now, pain relief for pains generated from these areas may be partial with rest if it is degenerative, because don't forget that we're talking about degenerative spinal disorders now, or it may be associated with changing positions. Now, predominant discogenic pain is usually worse on sitting, because when you sit, The disc, especially the lumbar disc, you put them under pressure, because when you sit, it now becomes axial pressure. So you put them under direct pressure and their pain tend to be worse. Now, with twisting, also, their pain can also be generated. Bending and lifting and straining activities will aggravate this group of pain. Now, pains from these areas can be with or without radicular pain symptoms. And facet type pain is usually worse with extension type activity and is associated with abnormality of spinal movement rhythm. Now, second one is inflammatory spine pain. Inflammatory spine pain basically is pain generated from spondyloarthropathies, your ankle, the psoriatic arthritis, reactive arthritis, orthopedic spondyloarthritis. Now, these conditions some of them, they are often genetic and they are often not restricted to the spine. They often involve other joints, small joints, hips, and shoulders. It usually starts with this inflammatory condition. The stiffness starts in the morning, it improves with activity. Prolonged recumbency or prolonged rest or inactivity makes the pain worse, and activity reduces the pain. And oftentimes it progresses throughout life, causing marked stiffness in these patients. It can be distinguished using x-rays. Depending on the type, you have the bamboo spine, sacroiliac pseudo-widening erosion, you have sclerosis of the sacroiliac joint, and you can have peritonitis in some of these conditions. Trauma is another cause of spondylogenic pain. I mean, I don't have to go into town on trauma. You talk about the difference with trauma is that its onset of activity vary depending on the type of trauma. Minor soft tissue trauma, when patients sustain them, they may have a delayed onset of pain. Starts with an initial discomfort and the pain worsens over the next few days. Now, occasionally it can cause intermittent pain in the future, but it must be addressed because in some instances it can result in chronic pain. Now, major injuries, of course, pain is severe and is immediate in onset. Infections as another cause of spondylogenic pain. I mean, we're in the tropics, we're talking about pyogenic infections, granulomatous infections. They have varying patterns. But I mean, commonly we say they may be associated with night sweats, fever, some constitutional symptoms if these patients are not immunocompromised. In immunocompromised patients, you may not observe some of this symptomatology. These conditions are common in quite a number of people, but immunocompromising conditions like diabetes and HIV make them more common. They are more common in those patients. It's a disease of the very young and the very old. Osteoporotic compression fractures are also another type of spondylogenic pain. Now, osteoporotic compression fractures are basically of three types. You have the senile, you have the postmenopausal, and you have the idiopathic. Now, the patient, proper history from these patients will guide you. Oftentimes, the patient must have been complaining of long-term pain, especially axial pain, when the patient sits or stands upright, not during the process of sitting or standing, but sitting and standing. Patient comes of pain because they have microfractures. So subtle traumas, patient complains of pain. At times, the subtle trauma may accumulate into one single event and patient develops major fractures. The pain then becomes severe and almost incapacitating for some of these patients. I mean, some of these patients may end up with neurologic compromise at the end of the day. Tumors. Tumors are another cause of spondylogenic pain. They are peculiar. Some of these patients have a history of a tumor, history of passage of blood by urethra, history of hematochezia, hematuria, hematemesis, constitutional symptoms, um, loss of appetite. It's often caused from vertebral destruction and associated instability that comes with these tumors. Night pain, most of these patients usually have constant pain. Even at rest, they have pain, and it can be really devastating. Now, so a brief recap, we've said that low back pain, back pain generally can be classified into spondylogenic, neurogenic, viscerogenic, vascular, and psychogenic. And we also have said that the spondylogenic pain can be either structural spinal disorders, that is degenerative pain, degenerative disorders, inflammatory spine pain, mainly from spondyloarthropathies, tumors, which can be either primary or secondary from within the spine, which often causes destruction of the vertebral body, infections, either pyrogenic or granulomatous, and trauma, whether subtle or whether minor or major. And we talked about osteoporotic compression fractures. So now we're going to go to the neurogenic pain. Neurogenic pains basically means that pains that are generated by the nerve itself. It's not just conducted by the nerve itself. The nerve itself is the pain generator. Neuropathic pain, believe me honestly, is extremely painful. Oftentimes, it is worse than nociceptive pain. Patient describes the pain as deep-seated pain. It can be caused by either irritation, tension, or compression of nerves, and at times it can be referred, what you call sympathy, to structures that are innervated by the same nerve. Now, it's not all neurogenic pains that result from nerve compression. There are some that mimic nerve compression, spinal nerve compression, like thalamic tumors, arachnoid irritation, neurofibromas, epidermomas, cysts, and tumors around the nerve roots. But the presentation is that patient presents almost similar to a disc herniation causing a nerve root irritation. Viscerogenic pain means that pain that is generated from the viscera around the spine. So in the upper back, you're looking at the lungs and the pleura, the ribs as well. In the middle and upper lower back, if I can use that term, we are talking about the kidneys. In the lower back, we're talking about the pelvic viscera or lesions of the lesser sac. Now, these conditions can be from infections, just disorders of these organs. It can be infectious diseases in these organs. It can be tumors in these organs. It can be trauma to these organs. It can be some what I would call non-tumor and non-infectious conditions of these organs. And what they do is they cause pain in the back, and it's actually a referred pain. The pain is usually deep-seated. Changing position in the back usually does not alter this pain, and patients often have other symptoms that are related to the originating organ. You can differentiate it from spondylogenic back pain because, like I said earlier, it's not aggravated by activity, neither is it relieved by rest. And the patient, if a patient is generating pain from the kidneys, it will tell you that the pain is deep-seated. Your palpation of the back may not generate significant tenderness, but renal angle tenderness will become significant. So it's just about relating it to the structure that is generating the pain. The vascular structures around the back have often been ignored as a possible cause of back pain. Unfortunately, some of them can be fatal and they are often missed. And patients that have these conditions have been referred to as patients who may have psychological disturbance because of poor evaluation of the pain source. Now, abdominal aneurysms present with boring, deep-seated lumbar pain that's often unrelated to activity. So if a patient complains of deep-seated pain, tendencies for one not to think about that. I mean, we may even be more likely to think of a viscerogenic pain and less likely to be a vascular back pain. So this must be considered. Insufficiency of the superior gluteal artery will cause a buttock pain that is similar to a claudication pain around that buttock area. And it may radiate like along the sciatic nerve distribution. Now, intermediate claudication mean to different. We as spine persons, as orthopedic surgeons, we are expected to be able to differentiate between neurogenic intermediate claudication and vasculogenic intermediate claudication. In actual fact, it's a very common question in the exams. Once the patient presents and you see the patient has claudication, the old examiners are likely to ask you to differentiate. I mean, how would you be able to differentiate between a neurogenic claudication and a vascular claudication? It's just about being logical with it. The vascular claudication is caused by vascular insufficiency and the generation of lactic acidosis and other toxic metabolites. So it's a pain that's going to get worse with activity, and it does not get relieved immediately by rest. But the neurogenic claudication in its own case is caused from canal stenosis. And if a patient, slight change in posture, I mean, a patient that was standing and walking sits and it was like he never experienced the pain. So we must be able to differentiate. There are like 5 major differences in the differentiation, the so-called climbing the stairs and coming down the stairs, differences, riding on a cycle, that will make vascular claudication worse and will not aggravate neurogenic claudication. So we must be able to differentiate these two conditions is extremely important. Psychogenic back pain. Psychogenic back pain is a more difficult pain to manage. Oftentimes, poorly managed chronic back pain ends up being psychogenic. In actual fact, a significant amount of chronic pain will end up being psychogenic. Then, and it generates a negative feedback cycle. The patient tends to be less believed by friends and relatives and even the clinician. And you think that all you need to do is to just apply your drugs and the patient will get better. And among some people, it's assumed that the patient never had any pain at all, and that the patient is just pretending. I must tell you that psychogenic back pain is real. Most of the patients have back pain. It may be over projected, and it may come with other symptoms. Some of these patients have been known to be suicidal, and there must be a good attention must be paid to them. I would advise proper history taking, family history, social history should be taken amongst these patients in their management. Now, back pain, acute back pain differs amongst different age groups. This is not sacrosanct, but it's worth noting. First of all, any severe disabling pain with consider symptoms, we must look out for a serious underlying pathology. And most spine degenerative disc pain peaks around the age of 35 to 55. Amongst infants, infection is a common cause of back pain, as well as among adolescents. But with adolescents, you must look out for spondylolysis, Schumann's disease as well. In the young males, I mean, talking about young adult males, 25, 20 and above, toward to middle age, This degeneration is a very common cause of back pain. Either it's premature or is dormant degeneration is a common cause of back pain among this age group. Spondyloarthropathies is also common among this age group. The history of trauma should also guide us to know that it's a traumatic cause of pain. From middle age to the older adults, degenerative disc disease is a common cause of back pain. In the older age group, infections is common. Osteoporotic compression fractures are also common, especially amongst women or amongst some very elderly men. And tumors, secondaries especially, either from the prostate, from the lungs, from the breast, should be looked out for. How do we diagnose these conditions? We've talked about a wide range of conditions, each with its own. The only thing that is common to all of them is acute back pain. Most of the other symptomatology vary. So, for a patient that has infection compared to a patient that has tumors, the symptomatology varies widely. But the common thing is the pain. So, first of all, the pain must be well defined. What time does the patient feel the pain? What are the activities that bring the pain? Does rest reduce the pain? Is the pain always there? What is the severity of the pain? Always make it a habit to score pain. It is objective and it is scientific. Know what any one of them that you want to use and apply it. So that when you're talking to people, to your colleagues about pain, you can say this was a pain score that this patient had, and this is the particular score that you applied for the patient. So defining the pain is extremely important, and it differentiates between a wide range of causes of acute back pain. Drug history. Many of these patients may have a prior history of drugs or drug abuse or drug consumption. Neurology is extremely important. Does this pain come with either paresthesia, weakness, or outright paralysis? Patients who present to you with pain as well as paralysis, you quickly have to think about the possibility of tumors and tumors, vertebral collapse, either secondary to tumors, osteoporotic compression fractures if they are elderly. You think of infection if they are also elderly. In the middle age groups, you think of a herniated disc. So the neurology is extremely important, and it guides one to the possible etiology. The presence of continuous symptoms helps, and it tells you that this patient has had some background underlying problems before this acute condition now started. So it's important to listen to the complaints of the patient, try and decipher the possible cause, and look at the cause of the pain. Was it that the patient had a history of pain in the past, or patient had some chronic abdominal pain? What other things are related? And quickly relate to the complications. The complications we are talking about is loss of neurology, and its accompaniments. That is weakness, loss of sensations, sphincteric dysfunction, or outright paraplegia amongst these patients. Because we're talking about infections and other causes, always remember that blood works are very important. Complete blood count, the CRP, that is the C-reactive protein, the ESR. In talking about tumors in this institution, we always think about the myeloma, and then we do the appropriate testing for that. Imaging is we are being orthopedic surgeons. Imaging is our guide. It helps us to look in to what we cannot see, but that is after you have taken a proper history. X-ray is your first image. First line of imaging. Always do the X-ray. Now, where fractures where you think that it's more of a bony condition and less of something. An MRI will help to show where there are tumors, it will show where there's an infection, where the abscess is collected. It will help define the investigation. Where is necessary, do all necessary investigations so that you can help the patient. What are your strategies for managing these patients? The first one and the commonest one, the first one you should think about is non-operative management. Because we're talking about acute conditions, I would advise that the first thing is analgesia. That's the first thing patient will need, pain relief. Please, as much as possible, do not hold back with pain relief. Don't try to be the preventer of drug addiction. If your patient needs pain relief, give appropriate pain relief. Pain is very subjective, and severe pain requires strong analgesia. Your patient should not present to you in acute severe pain and you are trying to give oral non-steroidal drugs. I'm sorry, you wouldn't have helped the patient. Nerve modulators can be used alongside adequate analgesia. Use of antibiotics will come into play where you're managing infection, whether it's pyogenic or granulomatous infection. Muscle relaxants are not drugs that I particularly fancy. They have their own place, but I think they are often misused or abused. Don't forget that the responsibility of the muscles, it is to help stabilize the spine. And where the muscles sense that there's some degree of instability that is coming in, the muscles tend to become tonic. They go into tone. So the application of muscle relaxant for a patient where the problem is not purely of muscular origin is may be counterproductive. Chemotherapy may be necessary if it's a tumor you are managing. Injections can be useful and also help in this condition if you think the use of epidurals has been very helpful when in neuropathic pain, especially neuropathic pain that is that where you have neuropathic pain being caused by spinal nerves and the patient is not fit for surgery, or patient is not ready for surgery, or the irritant is not, you think you can manage the irritant by infiltration without necessarily exploring. Operative management is, if you see I've not added anything here, it's a wide range of surgeries, ranging from spine surgeries to pelvic surgeries to chest to thoracic surgeries, from decompressions to stabilizing surgery, is a wide range. But suffice to say is that your operative plan must be tailored towards your diagnosed cause of acute pain. Now, what are the take homes that I want us to take here? One is that we're talking about acute back pain, irrespective of the cause. Prompt analgesia, prompt, adequate, effective analgesia is key to preventing the pain from being chronic and then establishing a psychogenic path. That is one. Proper evaluation will help you to decipher the likely etiology or cause of this pain. And it will help in planning for therapy. Now, we must think widely. We have said that acute back pain the causes vary from spondylogenic to viscerogenic to neurogenic to psychogenic and to vascular. So we must think widely. And some of the causes are such that if you miss them, or if we miss them, by the next time the patient is presenting to the physician, patient may be presenting paralyzed. Related to age, when you relate it to age, chances are that you can narrow the likely causes. And symptomatology and investigations should be tailored along the likely, your investigation should be tailored with the symptomatology of the patient. And always remember, even though the images are very important, always manage the patient and not the images. Thank you very much.
Thank you very much, sir, for the very lucid explanation and detailed explanation of what we should encounter and what we should look for when we're thinking about managing patients with back pain. I would welcome comments, questions from anybody who has any questions. You can go ahead and unmute yourselves if you want to ask a question. While waiting for others to ask questions, I'll read some of the questions that have been in the chat room. Someone asked what type of physiotherapy is advised. A lot of times we send patients for physiotherapy and we just say, go for physiotherapy. What exactly should we expect to be done at physiotherapy department, and what should be done, what should not be done in the physiotherapy department?
First of all, it will help every orthopedic surgeon, especially spine surgeons, those are interested in spine, to know that the physiotherapist is your friend. And they are there to help you and your patient get the best possible outcome. And I would say that in every institution, you identify effective physiotherapists, but you must communicate with your physiotherapist. If your patient has severe osteoporosis with osteoporotic fractures, you're going to make the conditions worse. If your patients have tumor, chances are that. Sorry, I'm having echo. And it's not from me. Can I continue?
You can go ahead, sir. I muted you.
Okay, fine. So if the patient has a tumor, all those destabilizing conditions that have affected the structure of the spine, you have to hold back when you are sending for physiotherapy. But if the acute pain is just from muscles, or you think there's some mild nerve irritation, because for nerve irritation, a lot of patients cannot tolerate physiotherapy. But if it's a mild nerve condition where you have given your analgesia, you're sending the patient on neuropathic drug, the physiotherapist can help you. You discuss with your physiotherapist, what exactly do you want to do for this patient? And you let your physiotherapist know what you don't want for your patient. If the orthopedic surgeon is not blind to physiotherapy, if you are blind to physiotherapy, you just send your patients there, you don't know what should be done, what should not be done, then you are the one that has generated problems for your patient. So you must have a fair idea of what you want for your patient when you are sending your patient. And in acute back pain, the role of physiotherapy is actually limited. You must have evaluated the patient to conclude as to what the likely cause is before you now invite the physiotherapist to come and join you. If it's from muscles, from nerve treatment, from nerve, mild nerve irritation, from facet joints. Those are things that you can work with your physiotherapist to either apply the cold therapy, apply massage if it's necessary, apply. I don't believe in traction. I don't encourage anyone to put my patients in traction. You understand? If it's any of those conditions, if it's from mechanical causes, from mechanical instability, from loss of muscle tone, your therapy can help you. But it's as far as I understand the question, whatever you are going to do will depend on what your likely diagnosis is. There's a role for physiotherapy in many patients, but there is a time when their role starts. For some, it's post-operatively. Thank you.
Thank you, sir. Dr. Loide asks, what are the options of management in patients with unresponsive acute back pain, usually adolescents and middle-aged patients, despite giving strong analgesics and opioids? He says they are quite common where he practices.
Well, I would encourage Dr. Loide, sir, to reevaluate his patients. You have to reevaluate your patient. Most patients will respond to analgesia. Now, the response may now be transient, depending on the condition of the patient, whether the patient is a drug addict. It may be transient or it may be very effective. But the analgesia in itself is to help you take away the pain and then continue evaluation. By itself alone, is not the therapy. It's for you to take away the pain, evaluate the patient. For some of the patients, analgesia, opioids, as well as non-steroidals will just manage the patient with nerve modulators. For some, they will need more than that. But if your patient is not responding to opioids, it's either your opioids are not good, or your patient's constitution, or patient is a drug addict who has been abusing opioids, either tramadol or cocodamol or pentazocine. So when you give it to the patient, it's like you are giving water and you have not done anything. So it's for you to evaluate your patient properly when you are giving these drugs to them. But that does not, whether the patient is addicted to the drug or not, if you solidly know or suspect that a patient is in pain, then you owe the patient some pain relief. Thank you.
Yeah, thank you, sir. While waiting for other questions, maybe I should just add or ask your opinion. So you talked about muscle relaxants. I have found that in patients, when evaluating patients, especially when they have evidence of paraspinal muscle spasm, and they've begun to get that persistent pain because the muscles are now in spasm. So you want to try and relieve that muscle spasm so that it doesn't become a self-propagating pain. I found that if using muscle relaxants for a short period, 4 days, 5 days, while giving other analgesics, physiotherapy, and other things to address the actual problem that the patient has, I found that it seems to give them a more rapid response to even using the regular NSAIDs or opioid analgesics. I don't know if you have any thoughts about this.
Okay, thank you very much. Now, my very strong belief is that paraspinal muscles don't go into tone for no reason. Their role is to protect the spine. So when the spine now cannot hold itself, the muscles tend to go into tone to hold the spine. That is their job. That's what they are designed for. Now, for some patients, the paraspinal muscles are the source of injury. So they're going to tone from injury to themselves. Now, for those patients, the use of muscle relaxant, I don't have issues with. But for the other group of patients, I believe strongly that before you give your muscle relaxant, you must have a fair idea of the cause of the muscle spasm. Otherwise, if you relax the muscle of a patient who has mechanical instability and the muscles are doing their job to prevent either nerve injury from mechanical instability, and you relax them, then you may have done a disservice to the patient. So I'm not saying that, I'm not condemning the drug. I mean, this is a drug that, has helped a lot of patients. I'm just saying that you have to define your patient before you apply the drug, because those muscles don't go into spasm for no reason. Thank you.
Yeah, thank you very much, sir. I think that's clear. Do we have any other questions or comments? Back pain is a very common problem, something every orthopedic surgeon sees, whether you are managing spine patients or regular or general orthopedic patients.
My position is that every orthopedic surgeon should be able to manage back pain. It's the commonest, it's so common a condition that you can't run away from it.
Yeah.
So everybody should be able to manage back pain to an extent, to a reasonable extent.
Dr. Kevin Ikechukwu, please go ahead and ask the question.
Thank you, sir, for the elusive presentation. Please, I would like to know whether use of lumbar support orthosis has any role in the acute management of back pain. Thank you.
Thank you, sir. Lumbar support is good for most back pains if you use it for a short duration while you are evaluating the patient and you are planning for definitive therapy. It's very good. It strengthens your muscles. The muscles are in tone, for example, for whatever reasons, because of acute back pain. You give a lumbar support, it further supports the muscles. Now, but when you use lumbar support for a particular duration, it now becomes counterproductive. Beyond 3 weeks, I've seen documentation that beyond 3 weeks, if you don't have good reasons for using it, it becomes counterproductive, because at that stage, your muscles then decide not to work because the lumbar support takes over the function of the muscles. But for acute back pain, it can help. But you must decipher what you are managing. Say, for example, you are managing a patient that has pyogenic spondylitis, and you think that you've evaluated the patient, you started the patient on lumbar support, let me say, I won't say lumbar support, I will say back support. And you now find out, look, the way it's looking is like it's unstable. So you can then apply that lumbar support until you think stability has been attained. So that would be a proper use. So I use them, but what I'm saying is that, look, you must evaluate before it's used. But it's helpful. I am more inclined to lumbar support for back pain than muscle relaxants.
Thank you, sir. Someone asks whether there are specific indications for use of epidural injections other than patients who decline or are not fit for surgery. Oh,
yes. Epidural infiltration actually is applied. If you look at the process, what we do is to deposit depot steroid, whether it be methylprednisolone or depot dexamethasone or triamcinolone, is to deposit that steroid into the epidural area. And what it's supposed to do is to reduce inflammation and irritation of the spinal nerves around that place. So if there's anything if there's spinal nerve irritation in that place, and you feel there are spinal nerve irritations that I see, and I feel that if I decide to go and do surgery for this patient, I'll create more trauma than the disc is creating. It's just a bulge of a disc. So it will help that patient. But when a patient has frank disherniation, then epidural infiltration is not the recommended therapy. But there are patients who will tell you that, look, doctor, I don't want surgery, or patient is not fit for surgery. So you offer, it's an armamentarium that you offer. But it's for neuropathic pain, it's not for nociceptive pain. Epidural infiltration is not for low back pain. Thank you.
Thank you, sir. Someone asked, what are your peculiar thoughts on osteoporosis-induced back pain?
Peculiar thoughts. Wow. I must say I'm not an authority on osteoporosis-induced back pain, but I have, in my own small experience, osteoporosis-induced back pain in the absence of a frank fracture can easily be managed. A lot of patients do well on your cocktail of drugs, your vitamin D3, your use of bisphosphonates, and calcium. Now, the only thing I notice is that people are very conservative on their use of vitamin D3. I see patients who are on 600 international units per day when they should be on 5,000 per day. And they can be conservative about the use of calcium as well, which should be about 1,200, 1,800 per day. Then you can now add and support with bisphosphonates or with calcitonin supplements. So I've seen a lot of patients with osteoporotic induced back pain who, with therapy, within 3 to 6 months, they get better. Your therapy is not a short course therapy. It's a long course therapy. When you place the patient on treatment, because most of them are postmenopausal, you let them know that it's for life. Because at that stage, they already are osteopenic. So it's not just the back pain that is caused that you're managing, you're also trying to manage the osteoporosis itself.
Thank you, sir. Dr. Oloyede, you want to ask a question? Dr. Oloyede. Okay, well, maybe we can.
Hello, sir.
Yes.
Yeah, good evening, sir.
Dr. Oloyede.
Yes, sir. Yes, sir. Thank you very much for the wonderful presentation. I think I've learned a lot from this. Sir, my question is on, I'm always having this group of people between 7, 8, 9, 10, up to 11 years. With this issue of recurrent back pain, sometimes with neuropathic symptoms relating to their lower limbs. Now, some of them, when I send them, I usually evaluate them, then send them for X-ray initially, infection workup, and some that can afford MRI, I do for them. But most times I find out that there's usually no specific finding on the MRI. Even sometimes when I manage them initially, give them analgesic, they don't respond, I just refer them to Ibobi for further care. For such patients, especially those younger age group, what are the possible causes and what we can do for them?
Thank you, sir. I think you are very lucky because I have not seen so many children with back pain as well as neuropathic symptoms radiating that far to the back. I've not seen many, quite frankly. But this is what I know, that in children, infections first. Trauma next. So when you are managing a child, children most of the children that present with low back, with back pain that I've seen, they're usually an underlying, there's no infection, there's usually an underlying history of trauma, either falls in school or assault by colleagues or by wards. There's usually a history of trauma that if you dig deep, the child will volunteer to you. That's one. Also, school bags, this rucksack that children carry. I have seen children that carry rucksack with a weight twice their weight. There is no way that child will not complain of back pain. But what I read somewhere, I can't remember where now, is that the child's bag should not be more than 20-25% of the child's weight. And that's what I counsel most of my patients on. But pain, radiating, neuropathic pain in children, I don't have, the ones I've seen, I've always seen infection or something like that with it. I don't have a wide experience with that. Maybe some other people can say what their experience is with that. Thank you.
Thank you, sir. Someone also mentioned that for such children, one should also consider sickle cell disease as in them and kyphoscoliosis, I think. Yeah, kyphoscoliosis, that's what's written in. Someone asked if your opinion about red flags in acute back pain, things that one should look out for, that one should be concerned about in patients who have acute back pain. Clinical presentation.
I emphasized on red flags during the presentation. I emphasized on red flag causing pain. When I was talking about spondylogenic pains, I talked about the pain patterns. I talked about osteoporotic fractures, tumor, fracture secondary to tumor, or acute back pain secondary to tumor, acute back pain secondary to infection. The truth about red flags is that all red flags must be properly evaluated. At times, you don't find something there. It just looks like a red flag and it ends up being a yellow flag. So it's all about evaluation. That was why I said in managing acute back pain, analgesia is key. Thorough evaluation is key. Especially in patients where you suspect there's been a history of trauma, osteoporosis, tumor, infection. Thorough evaluation is key. And most of these patients will present with pain even at rest and often with neurologic symptoms. So it's about thorough evaluation of pain.
Thank you, sir. Maybe I should ask this.
Yes.
What is your recommendation for guidelines for investigating patients presenting for the first time with back pain? Patients of different age groups with back pain that you have not been able to attribute to a specific thing. I mean, for example, if a patient has obvious trauma, you're thinking of a fracture, it's obvious what investigations should be done. But we're talking about a patient coming for the first time, non-specific back pain, probably due to degenerative causes or whatever. When do you decide you need to investigate, or you need to take x-rays or MRIs or CTs and so on?
Thank you very much. Routine. The x-ray is a badge every patient carries. The patient comes with back pain, I ask them to go and do an x-ray. I don't make any assumptions about anything. Let me see that there's nothing there. Let me know how much pain you have. Then I do further evaluation. Usually, if I look at the x-ray, the pain is not so severe, there are no constitutional symptoms, patient does not have pain at rest or constant severe pain at rest, the x-ray will suffice, analgesic I will give to you. But the moment the patient complains about anything that has to do with neuropathic, you have earned an MRI straight away. If at the first presentation, a patient presents to me with pain that has a neuropathic component, the patient will have to do an MRI as well as an X-ray. Now, you have to understand that the patient has presented himself to you for evaluation, and some of these evaluations are time bound. So, for example, a patient presents to you with acute back pain, is severe. Patient has pain even at rest. You look at the patient. Maybe there are no constitutional symptoms ab initio, but patient has pain even at rest. You've done an X-ray, and you're wondering what I'm seeing here. Is it clear? Is it not clear? Order for an MRI, because you owe the patient evaluation and reportage. If you send the patient home and after 4 weeks he developed neurologic symptoms, he would not be happy with you. In actual fact, he will shop for somebody else. So when I saw Dr. A, I saw him, he didn't know what to do. He just said the X-ray and he gave me diclofenac. So you hold him back. I know that the MRI is expensive, but once patient has pain at rest, patient has severe pain, patient has neuropathic symptom, I order for an MRI, I don't wait. Let the patient say he can't afford it. Then I will know that it's documented that I requested for the appropriate investigation, but patient didn't do it. We have had patients who wrote letters of complaint from their lawyers that they presented in the hospital. They came at so and so time. They were walking when they came, and gradually they were still coming all the time, and they could no longer walk. And it was written by a lawyer. What protected the doctor was that it was documented that he requested for an MRI and patient never did it. So it's holding back is a double-edged sword. I know that it's expensive, but as a rule, once the patient has neuropathic symptoms, I order for an MRI. I don't spare it. Once you have anything that is neuro, MRI straight away. If you have severe pain at rest, I'll ask you to go and do an MRI. As well as an X-ray. X-ray is everybody comes
standard.
You don't come to an orthopedic clinic without an X-ray. Whatever it is a badge. You must come with an X-ray. You must have an X-ray. So that's
all right, sir. So X-ray standard for everybody.
It's a badge.
And then neuropathic symptoms or unremitting pain.
Unrelenting pain at rest.
To MRI. Yes, move on to MRI. Yes, I've also found that, well, in my clinic,
yes, sir,
any patient that comes for the first time with back pain, I see them myself. I don't allow the residents to see them, even if I'm going to be out of the clinic for a while. They wait for me, because I spend a lot of time explaining, especially the patients who have the common, in quotes, degenerative disc problems. So I spend a lot of time explaining to them the problem they have, the pathology that they have, the way the symptoms go, how it could start, where it could progress to. And I explain all the treatment options depending on how bad the pain is. And then I let the patients know that if we start at some level of treatment and we do not get significant or enough relief of symptoms, then we may have to progress higher and higher. And then I let the patients know that I put it back to the patients that if they are not satisfied with the level of with the level of relief of symptoms that they have after any stage of treatment, then they know that there are always other options available for them. But of course, if the patient has features that would require going all the way to surgery right from the onset, I'll tell them, well, sorry, in your own case, you need surgery directly, or you need to have epidural injections or something. But even for those who are just coming for the first time with back pain, not too severe back pain with activity and so on. I let them know everything, because you never know where they'll get to again, and they will hear that they had a cousin or somebody else who had back pain. They don't know the difference between their own problem and the person's problem, and then the person went to India and came back, and then the pain had gone. Whereas they are not yet at that stage. They are not yet at that stage, but they should know that if it gets to that level, then you will need to do something more. Someone asks that, do you do dynamic x-rays for patients as a rule? And what conditions do you do dynamic x-rays for them?
Well, thank you. I don't do it as a rule. I don't do it as a rule. Now, usually, when I have patients that have spondylolisthesis, grade 1, maybe middle-aged elderly with some spinal canal stenosis, and I want to decide whether to instrument or not to instrument, then I send them for that. If I see features suggestive of instability, I will make a conclusion pre-op that instrumentation is what I need to do. But I mean, these dynamic x-rays are not necessary in patients that have tumors, osteoporotic conditions, patients that have infections. It's basically in patients that have degenerative spine disease that you want to do it. So I just use it as a guide when I want to decide whether to instrument or not to instrument the patient. That's when I use it as a guide. I don't do it routinely.
All right, thank you, sir. Do we have any other questions? Looking through, I think you've already talked about the issue of skin traction. You don't do skin traction for patients. Muchale wants to ask a question.
Yeah.
Dr. Shobode.
No, I already put the question up, sir. Thank you, Dr. Ibrahim. I was wondering, I know, sir, that you typically would ask residents going for exams, the part 2 exams, how they would evaluate a 35-year-old with acute onset back pain. How would you, I know you put an age to it. You can say to old man. When you put an age, so in the interest of these residents, because they constitute about 40% of people in the room tonight.
Your voice is breaking, but I can hear you. I can hear you.
Okay, good. So, yeah, I said in the interest of this resident, because they constitute about 40% of the participants in the room tonight. I know you typically, you and other examiners would typically want to set questions like, how would you evaluate and manage a 35-year-old man with acute onset back pain? I know when you put pegs like that to it, a 35-year-old and the gender, you want to cone down the pathology that could be presenting in such patient to 1 or 2 or 3 pathologies. So if you can just quickly do justice to that, so maybe in 5 minutes, how you would evaluate and manage such patients. So.
Thank you very much. The approach to it is to, first of all, ask ourselves, what are the likely causes of acute low back pain in a 30-year-old in an African setting? You have to remember that in an African setting. So definitely the infections will be there. The spondyloarthropathies will be there. Trauma will be there. Disc herniation will be there, or early degeneration, let me put it like that, will be there. So we expect you to go into town to talk about those ones. If the candidate is going to mention other conditions, he must have a cause to mention them. For example, a candidate talks about osteoporotic osteoporosis as a cause in 30-year-old, he must be quick to add that patient who has chronically abused steroids. If he's talking about tumor, he must be quick to add the specific tumor that you are likely to see in a 30-year-old, and there are very few of them. So the evaluation starts from history. What I would advise is that candidates should evaluate, once you know the likely causes of acute back pain in that age, in an African setting, then it becomes easy to talk about the possible histories that you need to know, the likely investigations that you need to know. Don't forget that pain is universal to all the causes. So you must take a proper history of pain. And that the back is also universal to all the causes. So you must decide where the pain is. Is it in the thoracic spine or in the lumbar spine? Once you sort those two out, all you need to now do is to go into town as to likely causes. If it's infection, what are the things that you need to know from the history? What do you get from physical examination? What kind of investigations would you like to do? Definitely, when it comes to imaging for this kind of patient, you have to do the X-ray, the MRI, the CT. You may have to do that, depending on the cause. So if it's trauma, you may have to do a CT. If it's a disc degeneration, you might have to do it with neuropathy, you might have to do an MRI. An X-ray, like I said, everybody carries the badge. Now, your blood workup will depend on what you have added into the history of that patient. If you are thinking of a patient, a 30-year-old who is HIV positive, for example, who is immunocompromised, then you have to add all those to your investigation. Definitely, thinking about infection, a CBC, full blood count ESR, CRP is a no-brainer. You must request for that as investigations. Now, when you're now talking about your therapy will depend on patient's presentation. That's what they always teach us, that treatment depends on patient's presentation. So you're now going to town. If it's infection, what will you do? If it's pyogenic, what do you do? If it's granulomatous, what do you do? If it's trauma and the patient has subtle injury, if it's muscular injury, what do you do? We discussed about muscle relaxant. If the trauma is beyond vascular injury, enough for you to see signs that there was maybe a fracture there, then what do you do? So I think it's all about understanding the likely etiology of acute pain in that age group in the African setting. Most examiners do not forgive you if you forget that you're in Africa. They don't forgive you because there is a variation between the likely cause of pain. Schwann's disease is not common in our environment, but you should mention. Spondyloarthropathies, we see quite a number of them. More commonly, we see Angstrom and others, and psoriatic spondyloarthropathies. The GI spondyloarthropathies are not common in our environment. So if you go into town on that, the examiner is not going to appreciate what you're talking about. So that is the way I would approach that question. Thank you.
Thank you very much, sir. Someone asked, how often do you see dysplastic spondylolisthesis in children, and how would you investigate and manage them if you do see them?
Well, I don't see them often, but I do see them. But it's not like something you commonly see. It's not in our character in this environment to bring children to the hospital for back pain. It's not in our character. People usually prefer to see something wrong with their children's back before they present them. So I've seen quite a number, but it's not like what you see routinely in the clinic. I don't. Maybe somebody else has a different experience. I don't see them routinely in the clinic. But you see some of them that develop this problem as children and they have grown into adulthood. And a person will tell you that, look, I've had this pain there before with this swelling and this place looking like this for a long time, but my parents didn't bother or something didn't bother. Then when they now start developing neurologic symptoms, then they now present to you. Now, I have not had to operate on any child with dysplastic spondylolisthesis. But for the adults I've seen, the surgery is been simple decompression. Usually I use bone instead of the PIC cages. I use bone as an intervertebral spacer or intervertebral structure, and then I fuse. But I've not operated on any child with dysplastic spondylolisthesis. No, I haven't.
Okay, thank you, sir. Someone wants to use the opportunity of your being here to ask what exactly does one have to evaluate to declare a spine stable or unstable?
Spine, when we say spine stable or unstable, we are talking about mechanical stability. There are history, that is, there are clinical features that the patient will give, of mechanical instability that the patient gives to you. Now, the muscles of patients who have mechanical instability tend to maintain tone during the daytime. But after a while, the muscles suffer fatigue. At times it's in the evenings, at times it's when they are sleeping. So basic movements that you and I take for granted, rising from a sitting position, standing, turning, become very painful. And the pain is usually sharp, and it can be really excruciating for a lot of people. Now, for you to evaluate the stability, you now have to do x-rays. If you do an x-ray, even if it's a static x-ray, and you see features of spondylolisthesis, that is unstable. But dynamic x-rays are what will show you that even if it looks stable, with movement, it becomes unstable. Now, for most of them, surgery is not what I do for them. Most of them go through physiotherapy, they do muscle toning exercises, and they do very well. But for gross instability, that is now bothering of neurologic compromise, high-grade listhesis, grade 2, 3, then you have to do a decompression and stabilization procedure for them. But for most of them, for 95% of the ones I see, they do well with physiotherapy. Even when they have degenerative spine, they do very well with physiotherapy. They go for muscle, they go to the back school, we call it here. They go for muscle toning exercises, and within 2-3 months, they tell you that doctor is better. Now I sleep well. I don't wake up middle of the night when I turn. I don't have difficulty getting out of bed in the morning. I don't have pain when I bend down to just pick something. I don't have that sharp excruciating pain. And that is just rewarding.
Thank you very much, sir. Do we have any other questions? I don't see any hands raised or any other questions in the chat room.
I want to make a comment.
Yes, sir.
I want to appreciate Professor Numia for his comments. I like illustrations, but I had a crucial week and I had to put these things together. So I didn't have time to just load it with illustration. I would have loved to. So I really appreciate his comments.
Okay. Oh, okay. All right. Yes. Thank you. Thank you, sir. In the absence of other questions or comments, I want to thank
Dr. Ibrahim, I sent you a message.
Oh, okay. Sorry, I didn't see that. The chat message.
Can you quickly look at on WhatsApp? Can you quickly look at it so you can make the announcement? Look at the announcement.
I've seen that. I'll make that. All right. So in the absence of other questions, we want to appreciate Dr. Alimi for taking his time and sharing his experiences with us all. I'm sure it will be of benefit to every one of us. Tomorrow will be another presentation. We'll be talking about skeletal dysplasia and Blount's disease. And like we announced last week, we would want tomorrow's presentation to be very interactive. So we encourage people to bring along x-rays of patients that they have seen or they would want to manage, so that after the short lecture, we can have those x-rays presented and we can have some discussions around them. It could help if you send the x-rays to me or to Dr. Shobode beforehand, maybe with a short description of the clinical presentation, so that we could help to share the images during the presentation. That will make things go smoother. So thank everybody for
Dr. Brian,
coming. Yeah.
Dr. Brian, it would also help if on your own part you could reach out to the pediatrics auto department in Ilorin, in Igbobi, and in Dala. A few guys there that do a lot of these angular deformities around the knees, please, so they can make presentations tomorrow.
Yeah, that would be nice.
Okay. All right. That's fine. That's fine. Okay. All right. So we'll do that. Thank you, everybody, for coming. Thank you very much, sir, for your time. Thank everybody. Tomorrow will be another day. We'll see you
Sorry,
all
Dr.
at 4
Ibrahim.
p.m.
Also
tomorrow.
make announcement on our YouTube channel, please.
Yeah, sorry, the YouTube channel, as we've all seen, I'm sure most of us have seen the messages. We have a YouTube channel now. So we encourage us to subscribe to the YouTube channel, so you have access to the presentations live, even if you're not able to join the chat room when the participants are too many. And you also have access to even see some of the presentations outside the time of the presentations. And then let us also know if you have any problems accessing the YouTube channel or the presentations on the YouTube channel.
Dr. Ibrahim, are you still there?
I'm not sure if Dr. Ibrahim is still there, sir.
Maybe you should take over then. I think maybe network has checked him out.
Network has happened to him, sir. Okay, sir, on behalf of, can you hear me, sir?
I can hear you clearly, sir.
Yeah, yes, on behalf of the moderator, that's Dr. Ibrahim Abdulhakim Badebo from University of Ilorin Teaching Hospital, and I'd like to thank, and on behalf of the president of the NOA and the chairman of the Education Committee, Professor Onumia, I would like to thank the presenter, our own chief, Dr. Mustafa Alimi, most kindly for this presentation. It's always nice to have you around and to share your wealth of experience as far as spine is concerned and the pathology of the spine. We thank you, and we hope that whenever we reach out to you again, you would oblige us and make this presentation. We know we can always rely and rest easy for you, sir. And also, Professor Onumia, sir, I would like to be the first to invite you to give a lecture on spine trauma. That will be sometime in May, I believe. I think Dr. Kemi Lawani will reach out to you, sir. We believe you would oblige us as well. So thank you, everybody, for participating in today's webinar. We hope to see you tomorrow at 4 o'clock. The classroom will open at about 3:45. And Dr. Adedapo will be taking us through skeletal dysplasia. As Dr. Badebo said, Dr. Ibrahim said, skeletal dysplasias and Blount's disease with a lot of case presentation. And if you do have cases to present, whether you've managed them, yet them, you're welcome, invited to please discuss these cases with us. Once again, I'd like to thank Dr. Mustafa Alimi for doing us this honor of presenting acute back pain. He still has a lot more lectures to present. We hope to see all of you in subsequent presentations. Thank you and have a good evening. Thank you, sir.
Thank you, sir.
Bye-bye, sir.
Bye-bye, sir.